Hey everybody, welcome to All You Need to Know. Today we're still talking about syncope. If you watched our video from last week, we discussed the etiology of syncope and how to risk stratify these patients. Today I really want to get to the meat of the conversation, which is the workup of syncope and how to do that efficiently. And I especially want to highlight the things that we don't need to be ordering on these patients. Okay. So as we mentioned last week, taking a good history, performing a good exam, grabbing an EKG, is going to help you determine the etiology in a lot of cases, is going to help you risk stratify. And for most of your syncope patients, that's all you need, you're going to be done. But as I said, I want to spend time talking about some of these other tests that we often order. So the first thing that I want to discuss is orthostatics. Now we're going to spend a little bit of time on this because, as I keep saying, this is probably the most common cause of syncope in our patients. So this leads me to my next take-home point, which is check orthostatic vital signs yourself. Now, the reason for that is it is so frequently done incorrectly in the hospital, and we're using that data at face value to make big management decisions. And so to ensure that you're getting accurate data, I think the physician or APP needs to be checking the orthostatic vital signs themselves. So if I'm telling you to do that, let's talk about how to do it. And this is the old way that it's typically taught, but I want to talk about a different way of doing it. So the first thing that needs to happen is the patient needs to be resting and lying flat for 5 minutes. Okay, this is almost always skipped in the outpatient world and very frequently skipped in the inpatient world. But it's really critical in getting an accurate initial pressure, which we're basing our diagnostic criteria off of later. And so we got to get that first pressure right. So make sure the patient's lying flat for 5 minutes and check the initial pressure. Okay. Then you can have them stand up and check their pressure upon standing. Now, we're all pretty familiar with the criteria that we use to determine positive orthostatics, and that's a systolic pressure that drops more than 20 and a diastolic pressure that drops more than 10, right? What about heart rate? So the European Society of Cardiology guidelines, they actually don't list heart rate as one of the diagnostic criteria. And the reason for that is the heart rate response is often blunted in patients who have autonomic failure and in certain patients who are on certain drugs. At the same time, it can be a little bit exaggerated in our patients who are hypovolemic or anemic. So it provides some context, but don't use the heart rate independently. Now, another criteria that the guidelines did include was that if the systolic pressures ever drop below 90, regardless of the absolute value in the drop, that it should be considered positive. Now, I don't know if I entirely agree with that, though I think it's pretty safe to say that if your pressures are below 90, your patients will probably be symptomatic. Now, the other thing to consider is that if you check the initial pressure upon standing and it's normal, recheck it again 3 minutes later. And the reason for that is a fairly significant number of patients who have orthostatic hypotension have delayed orthostasis, and it can happen several minutes after standing. Okay, so to recap, make sure they rest for 5 minutes. No need to check a sitting pressure. Instead, check another pressure 3 minutes after standing if that initial standing pressure was normal. Okay. All right, let's talk about some more tests. What about telemetry? So, in short, if your patient falls into this green box, they probably need tele. Every other patient probably doesn't. All right. So, if a patient has a normal EKG, there's no other significant cardiac diagnoses, or there's no other significant risk factors, or if their history doesn't fit with cardiac syncope, I probably wouldn't put them on tele because it's probably going to be very low yield. And don't forget how burdensome these tele boxes and all these wires can be, and they can be especially troublesome to our elderly patients who I've already said are probably in there for orthostasis anyway. Now, on the other side of the coin, if you really think the cause of syncope is an arrhythmia and you don't capture it on tele, ensure that you are arranging the appropriate post-discharge cardiac monitor. Because even in cases of cardiac syncope, odds are these patients are in the hospital for less than 48 hours, and so you may not capture an event during that 48-hour window. And so If it's higher in your differential and the workup's negative or they're in the hospital, make sure they have the right type of monitor when they leave. All right, what about a CT head? It really kind of comes down to two questions. Is their exam abnormal, and are they on blood thinners? If the answer is no to both of those questions, head imaging is probably going to be extremely low yield. So if there's no focal neurological deficits, if there's no history or signs of head trauma, and they're not on antiplatelets or anticoagulation, I would not get a CT head. It's going to be very, very low yield. All right, what about everybody's favorite, the echo? So similar to telemetry, if a patient has a reassuring history and a normal exam and a normal EKG, an echo is not going to change much, and I would not recommend it. We're going to look at some more data here in a minute, but there was a study that showed in high-risk inpatient patients admitted for syncope, an echo only determined the etiology in only 2% of those cases. Okay, so if an episode is clearly basal vagal, a patient passed out after seeing blood, or a patient has a classic prodrome preceding the event, probably don't need an echo. Now, on the other hand, if the patient complains of palpitations or chest pain or breathlessness with the event, or if they have exertional syncope or syncope while they're laying down, or if it happens with no prodrome, yeah, those patients need an echo. Okay, but a lot of them don't. All right, what about carotid ultrasounds? I hope we're not ordering these too frequently, but just to cover all our bases, let's talk a little bit about carotid ultrasounds. I'm not going to go into a lot of detail in the neurovascular anatomy, but there are multiple major arteries supplying blood flow to the brain, and there's also a redundancy of blood flow. And as a result, carotid artery disease results in focal neurological deficits as opposed to loss of consciousness. And the reason for that is because there's only regional hypoperfusion as opposed to global hypoperfusion. And if we go back and look at our definition of syncope, it has to occur due to global hypoperfusion. Okay? The European Society of Cardiology guidelines have pages and pages on telemetry and pages on echo. They have one sentence on carotid Dopplers, and it says, no study suggests that carotid Dopplers are valuable in patients with typical syncope, period, next paragraph. Okay? So I'm not saying that if you're concerned about a dissection or a TIA or a stroke or stenosis that you shouldn't get a carotid ultrasound. They can be very helpful in those cases. But in the cases of syncope, carotid ultrasounds will not affect management and will not give you the diagnosis as to why the patient actually syncopized. Okay, so I mentioned some data. Let's look at the study. Now, this study came out 10 years ago, which means the references to cost are probably outdated, but I think the medicine is still very applicable. So this table here contains all of the common tests that we get for syncope. So EKG, tele, enzymes, head CT, echo. It tells you the frequency at which they're obtained for syncope patients. So, for example, EKGs are obtained in 99% of patients with syncope. And then it gives you the total number of abnormal findings, how often it affected diagnosis, how often it determined etiology, and how often it affected management. Now, there's a lot of numbers here, but what I really want to highlight is that are these two green boxes. And that is orthostatic hypotension, or orthostatic vital signs, determined the etiology in nearly a fifth of cases, and it affected management in nearly a third of cases. If you look at all the other tests, from tele to cardiac enzymes to head CT to EEGs, carotid ultrasounds, they're all very low yield. Most of them are actually below 1%. Tele is at 5%. But everything else is extremely low yield. And what about cost? So this table here gives you the cost per test, and then it tells you the cost per test to actually affect management. At the very bottom is the orthostatic vital signs. It costs $17 for orthostatic vital signs to affect management. Okay. On the other hand, head CT costs $24,000. You had to spend $24,000 on head CTs until it affected management and syncope. And this was, like I said, 10 years ago. This number is probably 30, 35 grand now. The other thing to take into consideration is not only are these tests themselves expensive, we often will lose entire hospital days waiting on the test to be done. So we're not even factoring in cost of hospitalization. Okay, so what this data is showing you is not only is orthostatic vital signs the most, has the highest diagnostic yield, it's also the most cost efficient. Okay, let's wrap all this up and kind of summarize a few things. So pearl number one, history taking is the single most important diagnostic tool at your disposal for syncope. Pearl two, check orthostatic vital signs yourselves. As we saw, highest diagnostic yield, most cost efficient. We're making big decisions based off this data. Check them yourself. Make sure they're done right. Pearl number three, when it comes to other tests, be very intentional about who you order them in, okay? I'm not saying never order tele, I'm not saying never order enzymes, I'm not saying don't order stress tests, carotid Dopplers, head imaging, all that stuff. But make sure the history or the exam leads you down that road before you order those tests. Otherwise, they're going to be very low yield. Kind of related to that, a little pearl for the road on something that we haven't talked about. Pulmonary emboli are rarely responsible for syncope. Okay, so there was a study that came out several years ago called the PESIT study that said all these cases of syncope are actually being caused by PEs and we're missing them. A subsequent meta-analysis showed that that probably wasn't the case. Basically, the conclusion was if a patient has other clinical signs of a PE, shortness of breath, pleuritic chest pain, hypoxia, and they syncopize, of course, get the CTA. But if they're not having those other usually obvious clinical indicators, CTA is going to be as low yield as your carotid Dopplers. Okay, so be intentional, be judicious on ordering any test that's not an EKG or orthostatic vital signs. Okay, all right, that's all I got.